Very good evening, one and all. Very good evening, seniors, juniors. Very good evening, fellow doctors. A pleasure to have each and every one of you here today for an academic feast that is to follow. As we all know from the latest ICMR INDIPE 17 study, the prevalence of hypertension in India is far beyond 300 million projected. That would roughly put us at a prevalence of approximately 30%. And as we all know, in India, hypertension is responsible for 57% of stroke deaths, 24% of cardiovascular heart disease related deaths. Notably, challenges unique to India, as you all would have seen in your own clinical practice, are that even essential hypertension, not just secondary hypertension, but essential hypertension, has a very early onset in life, tends to have a more rural urban divide. Indians tend to come with a clustering of CV risk factors, with, as we all know, also a certain level of seasonal variation in blood pressure. Because of the low awareness, there also it's not uncommon to see patients coming with direct hypertension mediated organ damage to you, and ultimately you retrospectively diagnosing hypertension. So in this entire clinical gamut, it only becomes more important that we keep abreast with latest concepts as well as management of the same. To throw more light on the same, we have the most distinguished experts that we can think of who can take us through the journey for hypertension. I have the honor of introducing our moderator for the day, Professor Dr. Ketan Mehta himself, whom, as you all know, needs no introduction in the field of medicine. Nevertheless, I'll do the honors. Professor Mehta is a senior consultant at Suchak Hospital, Nama Healthcare Center, and Asian Heart Institute in Mumbai, has been the president of IMA Mumbai West in 2022-23, has been the honorary general secretary of the ISC, as well as of many other bodies, that is the ISC Con, ICP, NSphere. He's also in Epicon in 2005. He's the editorial board member of JAPI and the Journal of Medical Nutrition and Nutraceuticals, and a distinguished PG teacher for FCPS and an ex-teaching faculty at KJ Somaya Hospital. He's also a principal investigator for various distinguished trials like TIPS3, HOPE3, MARSH, TIPS-K, etc. Professor Mehta, an honor to have you, sir. Over to you.
Thank you, Dr. Parthasarathi, for the kind words. Dear friends, a very good evening to one and all those who have joined on a working day in the evening. And today we are going to have something different which has not been talked about since long. Obviously, I would like to thank Macleods Pharma and, of course, the Medwish team for arranging today's webinar. Now, this session has been a very important from the clinician's perspective, be it a family physician, be it a consultant in the field of medicine or a cardiology, because hypertension is the one condition which affects one and all. Dr. Parthasarathi has already given a fabulous statistics, and then you all start wondering, okay, this is all what's new to learn. We know everything about hypertension. We have heard about it. We know it. We have been treating it. But, it reminds me the quote from Sir Isaac Newton, who states that what we know is a drop. What we don't know is an ocean. And that is so much true when we talk about the hypertension. Dr. Partha has already talked about the statistics in hypertension, which is really an alarming figure. And we know that every 1 out of 3 Indian adults is having hypertension. And the problem is, it is undiagnosed, untreated, and unmanaged, and finally end up with complications. Over a period of time, we have learned that in the management of hypertension, it is not just controlling the blood pressure is important, but we need to control with medications which will have an add-on advantage, which can prevent end organ damage, and which can definitely have additional benefit. So we are not looking at the number games that, okay, you bring down the numbers of blood pressure. We need to have some additional benefit. And to discuss today on this, that means we are going to talk about today from pressure to protection and a molecule which has not been much talked about, that is olmesartan. Now, friends, we know there are various classes of drugs to manage the blood pressure, but we know that the RAS blockade, which is the one most important segment, which will be helpful. And then you have various classes in that. Initially, we all used ACE inhibitor, and then when the ACE angiotensin 2 receptor blockers came, we started realizing that has got a huge impact. Now, over a period of time, we have a various angiotensin 2 receptor blockers, but one of them which has stood apart, which is olmesartan. And today we have none other than one of the father in management of hypertension, Professor Dr. Redon Joseph. He would be discussing with us. Sir is a professor of medicine at the University of Valencia. He is the researcher emeritus in Clivia Research Institute, University of Valencia, head of the cardiovascular and renal risk group. Sir has graduated in medicine and done PhD from the Medical School of the University of Valencia, got his training in internal medicine and fellowship in nephrology and hypertension by the Northwestern University, Chicago. He was the scientific director of the Research Institute of Inclivia from 2009 to 2017, and he was having the most prestigious post, that is the president of European Society of Hypertension from the year 2011 to 2013. He has numerous awards and titles to his credit, and he has more than 800 peer-reviewed publications. It's really an honor to have Professor Dr. Redon with us. And sir, it is all stage is yours. Definitely, we would love to listen from you right from pressure to protection and focusing on olmesartan. Over to you, sir. Thank you.
Thank you. Then, good evening. Thank you very much for your kind words of introduction. It is a pleasure for me to participate today in this session that is entitled From Pressure to Protection and focus in olmesartan. But Professor, that have introduced what is the real problem in hypertension, that this is a very, very common disease, and also that impact and is one of the most important risk factors. Then it's very well known that in hypertension is the first cause of death attributable for individual risk factors in the world. But not only this, but also just for the disability adjusted life years. This is very well known, but what sometimes is not very well known is what was happened in the last 30 years. And you will see here, for men and women, you will see how the causes of death attributable to one systolic blood pressure increase is just increasing sharply. This increment is due to mainly one of the causes is because there is an increment of hypertensives over the world. You will see here this data from published recently that from 1990 to 2019, practically there are a double number of millions of people with hypertension. You will see here in men and women, and you will see here, this is India. You will see here that these columns are indicated the increment from the 1990 to 2019. Then this is an important issue. It is an important issue that mainly depends on two main factors. One is demographics. Population is living more time, and there is an increment of the more aged population. And the projection in the future is even worse. And the other one important is also the trend for overweight of the population. You will see here in that for adults and children, that the trend of progressive increment of the BMI for both adults, and even that this is more tricky, what is happening in children and adolescents. Well, it's clear that we have much more hypertensives, but also what is true is that, such has been commented before, that from all the hypertensives, men and women, those that are diagnosed is more or less the half. There is a lack of diagnosis, but also among those diagnosed, those that are treated are not all. Practically 70% are only treated, but those that are treated, the percent that finally are controlled is a very, very small proportion of the burden of hypertension in the world. This is really important. And why are the causes that are those treated don't achieve control? There are several ones, but years ago, I analyzed this issue, and then the causes are, for sure, that we are not touching currently the mechanisms of blood pressure elevation, but also there are some other relevant, such as the adherence of patients to treatment. If the patient don't take the pills, they are not effective for sure. And also, we have in our hands one other aspect that need to be into account, that this is the physician inertia. Many times we don't increase the medication that need the patients, and the patient is still in one medication that is not able to achieve a good control. Well, guidelines for the different societies and that from time to time release recommendations in order of how to touch better the mechanisms of blood pressure elevation, how try to improve the adherence of the patients, and also remind to all of us that with education, we need to act more, to be more proactive in treatments. Then the last of the guidelines that has been published is the European Society of Hypertension 2023, has been presented in June in the annual meeting, and it is going to appear in the December issue of the journal Hypertension. This is, I recommended the guidelines if you want to review in deep all the aspects related with hypertension. These guidelines are more a compendium or outdated information in hypertension more than recommendations, but the recommendations are also included. And recommendations, the first is what we need to start the treatment. What are the blood pressure thresholds to treat? Still, according to the European Society of Hypertension, the initiation of drug treatment is when the patient have equal or higher 140/90. But in adult patients with a history of cardiovascular disease, predominantly if it's coronary artery disease, drug treatment should be initiated in a high normal blood pressure range, in systolic pressure equal or higher 130/80. Then this seems to be that will be different to the recommendations of the American Heart Association. No, because they, at the time to start the treatment, we have the same recommendation, start to treat below 140 and below 90 in those subjects with a history of cardiovascular disease. And if this is the threshold to treat, what are the blood pressure goals? The blood pressure goals for office blood pressure is to bring the blood pressure in between 120 and 140 and 70 and 80. It is not recommended that the systolic and the diastolic go beyond these limits. But I put here one note that this is for office blood pressure. But what about the goals for ambulatory blood pressure monitoring or home blood pressure? We we don't have a very clear information. We don't have information that support what will be the best goals to achieve in these measurements that from time to time are more frequent. And to achieve this, what are the recommendations of the treatment? The recommendations start with a dual combination therapy, only recommended monotherapy in a few conditions. The majority of the patients with hypertension need to start with dual combination of a RAS blocker plus calcium channel blockers or diuretic. But what is also important is that it is better to prefer to use single pill combinations for this. If the patient is not controlled, that with this combination you can achieve approximately 60% of the control. Then you will add the three classes of drugs. Drugs for sure, I didn't say before, but diuretics will be thiazide or thiazide-like drugs. Then, if this is the recommendations, why it is better the combination therapy, and also what is better to use a single pill for the administration of the combination? What are the fundamentals and advantages of this? The fundamentals, the first is that according that the initial blood pressure that the patient have, the probability to achieve less than 140 goal, it is much better, whatever the blood pressure, baseline blood pressure, when there are a combination therapy, that is this in red lines. This is clear, but also many years ago, in 2013, one trial analyzed the impact of starting with combination therapy during the first 6 months of treatment, and those that receive by that only one drug, and then at 6 months start adding another drug. And in this case, you will see the advantage in reduce cardiovascular events and reduce even the hospitalization for heart failure in those subjects that started treatment in combination therapy from the beginning of the treatment. But together with the probability to achieve a better control, a better and faster reduction of risk, you have another advantage of the combination therapy. Combination therapy reduces side effects of the drugs. This is the typical example of edema of the calcium channel blockers, the hydropyridine. When you combine with, in this case, Olmesartan, you will see that there is a huge reduction in the risk for having edema. And in the other side, you also, if the patient is taking hydrochlorothiazide, the addition of one A or B reduces the risk of hypokalemia. You will see here that with 25 milligrams, if you don't have another drug, you have a risk for hypokalemia. But if you add one A or B, according you increases the doses, you are reducing the risk for the hypokalemia. And also, there is also a reduction in risk of metabolic effects. But what is the advantage of giving the combination therapy in a single pill combination. This is one study that was published by Professor Paraki 2 years ago, analyzing 44 studies. As you will see here, they take in account if the single pill improve over the combination by separate in adherence, in persistence, in reduction of blood pressure, diastolic, or in the rates of control. All that is blue, dark, and clear is advantage in adherence, in persistence of the treatment, and in reducing systolic, diastolic blood pressure, and also achieving higher rates of control. Then, if we have clear that combination therapy will be more useful and the single pill combination will be recommended, what is the fundamentals in the guidelines to recommend RAS blockers? And what are the differences in between use ACE inhibitors of ARBs in terms of tolerance and organ protection? First, it is clear the stimulation of AT1 receptor is implicated in the risk to develop stroke, that atherosclerosis with of course, blood pressure elevation, left ventricular hypertrophy, fibrosis, leading to heart failure or coronary heart disease, and also reduction of glomerular filtration rates or increasing urinary administration and glomerulosclerosis. Then blocking the presence of the angiotensin II or the binding to the AT1 receptor is effective in reduced risk, because also for atherosclerosis, angiotensin II is really important because it increases oxidative stress, inflammation, and endothelial dysfunction, and also influences sharply vascular remodeling. But what it is better to use ACE inhibitors of ARBs? Then the first is to look at side effects. You will see here a diagram. When you have a drug that you increases the dose, increases the efficacy, but usually reduce the percent free of secondary effects. This happens with ACE inhibitors, but this doesn't happen with ARBs. ARBs are better tolerated, mainly with one of the most typical side effects of ACE inhibitors, such as cough. But there is another aspect of this. This is data from the on-target study. On-target study, you remember, compare when ACE inhibitor with ARB. You will see how the discontinuation of the study medication due to side effects was more present with higher in the use of the ACE inhibitor. And then what about organ protection? Well, years ago was the controversy about that ACE inhibitors will be better than ARBs in the protection the cardiovascular and the heart damage, in order that to have a more risk for myocardial infarction and for the necessity to combination. Well, one demonstration of this, that this was not clear, is the on-target study too, because you remember there is 3 arms, 2 using also Olmesartan, but 1 ACE inhibitors, and you will see how all of them have the same cumulative hazard ratio of the primary outcome, the trial. But what about the protection of central nervous system? Then this is one study, 12 years of follow-up in cohort study, in that 403 participants with hypertension and mild cognitive impairment were followed to develop Alzheimer's disease. You will see the risk for not treated, this patient hypertension, those receiving several drugs, among them ACE inhibitors and these ARBs. Why the differences in the central nervous system? The reason and the explanation for this is the following. If you are giving ACE inhibitors, beta blockers, calcium channel blockers, then you reduce the amount of angiotensin II. But if you are using ARBs, what you are doing is blocking the 81 receptor, but the levels of angiotensin II are higher, and then stimulated 82 and 84 receptors, and then this seems to be that participate in protecting the central nervous system. Then, if we consider the ARB will be a good drug to treat patients with hypertension, are all ARBs equal? What are the similarities and differences? Similarities and differences mainly first in blood pressure reduction. In this meta-analysis that we published many years ago, you will see several collect several trials in which Olmesartan in different doses are compared with other candesartan, valsartan, irbesartan, losartan again, and all of this. In all of these studies, systolic and diastolic was reduced in more intensity with Olmesartan as compared with the others. And also, a few years before the other study, we also analyzed those studies performed with ambulatory blood pressure monitoring, in which was trials that compare drugs with placebo or drugs with calcium channel blockers. Drugs, and then we selected more than 11,000 subjects treated with different ARBs or placebo. And you will see the reduction in 24 during daytime of blood pressure. You will see that the highest reduction was obtained with Olmesartan as compared to all the other ones, when even we adjust for initial blood pressure, number of patients, age, sex, and dose. But if it is important this in daytime, it is also more important what happened during the last 4 hours of treatment. In other words, in the last hours before awake the patients. Then you will see how even the differences in favor of Olmesartan is even higher. And these differences in between the ARBs, it is also demonstrated in this study in which Olmesartan with amlodipine was compared with perindopril amlodipine, and then using 24 hours ambulatory blood pressure. The main differences were during night time. Then it is clear there is a long duration of the action of Olmesartan. Then it is very suitable for administration once a day. And in another study that we performed, we also checked another thing, that was in central aortic blood pressure or peripheral, what was the changes in comparative with also perindopril amlodipine, Olmesartan amlodipine. And you will see that there was a significant differences in favor. But here we, after this last point of the study, we leave 48 hours without treatment. And then the persistence of the reduction in blood pressure was better with the combination of Olmesartan and amlodipine than not perindopril amlodipine, giving again information about the duration of the time effect. And another thing that I didn't mention before, but these differences in between the different ARVs are maintained even when you are giving combination therapy, in this case with hydrochlorothiazide. With this, we demonstrated in many studies demonstrated that the olmesartan is more potent, reducing blood pressure and also maintaining during 24 hours. But what other additional effects in cardiovascular risk factors have olmesartan? What is the impact in inflammation? What is the impact in lesions of atherosclerosis? What is the action and the impact in remodeling of data? Well, several studies has been performed with olmesartan that have different mechanisms that are involved in the development of atherosclerosis that are reduced the Utopia study, reduced inflammatory markers. The BIOS study, reverse vascular remodeling, and the MORE study demonstrated the regression of some lesions in patients treated with olmesartan. Go to see some of this data. This is the Utopia study. Olmesartan reduced inflammatory markers, CRP, interleukin-6, monocyte chemoattracting protein 1, and so on, even greater than statins. In the BIOS study, as I told you, that the ratio volumen in coronary heart disease was comparing between atenolol and olmesartan, and you will see here the reduction after 52 weeks of treatment. And the more that you will see the changes in a plaque from baseline after the treatment and comparatively with what happens with the treatment with atenolol. And then even this, in another study, the Olivus, also demonstrated the impact on progression of coronary atherosclerosis, that assessing the changes in IBUS, the factor more important was olmesartan as compared to other ones, including statins, and also have impact in cardiovascular events. And this is also from the more there are changes in the plaque volume over time comparative with atenolol. Then, what about in other organ damage? Left ventricular hypertrophy. This is a study in which compare the reduction in left ventricular mass index as compared with candesartan. After one treatment of candesartan 6 months, the following 6 months, that olmesartan was able to be more intense at the time to reduce left ventricular hypertrophy. And what about urinary albumin excretion? All of you, for sure, you know roadmap in which olmesartan prevent and delay the development of urinary albumin excretion in patients with type 2 diabetes. Well, we have seen several aspects related with the molecule, but what are the capacity, the possibilities that we have for treating those patients, and you have in India in this case? What is the family of single pill combination with olmesartan? What is the blood pressure reduction? What are the control rates? Then you will see here all the combinations that you have in terms that with olmesartan in single pill combinations of 2 or single pill combination in 3. And I will say something to you at this point. You have much more possibilities that we have in our countries in Europe. In Europe, for example, we don't have combination with alnedipine. We don't have combination with a beta blocker. And what will be interesting that to use amlodipine with alnedipine? Well, all of you know that amlodipine is the blocker of the L channels of calcium entry in the cells. And then when you look at what happened in the kidney, there is no reduction of urinary excretion. In opposite, acylnidipine blocks not only the L, also the T channels that also do the same effect in vasodilation because it's one dihydropyridine, but also reduce the urinary albumin excretion. Well, whatever the case, you have multiple possibilities of combination therapy. And if you are giving amlodipine with these calcium channel blockers, you produce vasodilatation. If you are giving olmesartan, all these stats we have said before, but also this reduction of vasoconstriction, reduction of production of a synthesis of aldosterone and release aldosterone, and decrease also in the catecholamine. Or if you are going in combination with hydrochlorothiazide, you have that the acute impact of thiazide diuretic is to reduce the total peripheral resistance, but in long term, you have also natriuresis and volumen depletion. Then the combination, you are given the possibility to implement, to act in those mechanisms that I say at the beginning of my talk that are responsible that the patients don't achieve good control. And what is the impact of this? You will see here in data from the Trinity study. Trinity study was combination of olmesartan with hydrochlorothiazide or olmesartan. In this case, you see that the combination with olmesartan is much more effective. But then this more or less will be equal hydrochlorothiazide of amlodipine, but then when you use the triple combination, for sure, you increases sharply the control. And what is more interesting, you will see here what is the reduction during 24 hours of the systolic blood pressure. Then there is an increment progressively when you are adding the third drug here. But the same happens in another interesting study that was a similar study, the previous one, but in patients with diabetes. You will see that the rate of control of patients with diabetes then is increasing progressively, increasing the dose of olmesartan here and the amlodipine, but also when you achieve and you arrive to the triple combination, the rates of control, 140/90, are very high. And even those more demanding, such as 130/80. With this, we show to you data from many studies. But what are the evidences in real life? Well, here there is data from one study in Korea that was more than 2,000 subjects. When at these subjects, given one triple combination of olmesartan, amlodipine, thiazide, in hypertension that previously had different treatments. And you will see here what is the rate of control considering whatever the characteristic that the patients that you have. If I have patients with CKD, with cardiovascular disease, with dyslipidemia, diabetics, obese, people smoking, age more than 45 for male, 55 for female, and even control, high rates of control for a level of control of 130/80. But what is interesting is to see, according that the treatment that these patients are receiving previously, no treatment for sure, the reduction in systolic and diastolic is high. With those that are taking only one drug, the increment is also 2 drugs, 3 drugs, and even in those that are taking 4 or more drugs. This combination offers a significant reduction in systolic blood pressure and diastolic blood pressure. And then this was independent of sometimes the characteristics of the patients, the class of drugs that the patients are receiving. If are 2, if are 3, for 3 pills, for that 2 pills of different combinations. And there is another study, this in Japan, that also giving a dual combination of olmesartan and amlodipine as able to achieve very rates of control with a blood pressure reduction, the -10 in systolic, even -13 after 8 weeks of treatment. And finally, what happened also if these subjects control blood pressure at home? You will see how progressively, giving the following the weeks, then you will see how increases progressively the efficacy of this combination in that. And I go to show practically my last slide. This is a demonstration of the impact in inflammatory lesions of the carotid artery. Then this is a comparison in between olmesartan and amlodipine in patients in which were evaluated with PET or PET scanning, PET scan. Then you will see that baseline and post-treatment, how in the post-treatment the images, the intensity of the images that indicated inflammation has been reduced when not happen the same when you are using a calcium channel blocker. Then, dear friends, I would like to summarize a little bit what I have saying during the last 45 minutes. Olmesartan based has led to tailored therapy in hypertension management. It's highly effective with excellent tolerability, a very low discontinuation rate. In recent years, a number of single pill treatments based on olmesartan has been developed. I told you that you have even more that we have in Europe, that a fixed dose combination in dual or triple increases blood pressure reduction and improve target rate achievements. It's clear that the efficacy of olmesartan-based treatment means that a large proportion of patients can achieve target blood pressure. And in general, I think that it's important to maintain in our brains adding a second or third drug is likely to be more effective without increasing adverse events compared to increasing the dose of the existing therapy. And early use of single pill combination therapy can significantly improve hypertension control. Thank you very much for your attention, and I am open for answer the questions that you will have released for me. Thank you very much.
Thank you. Thank you so much, Professor Joseph. That was an amazing presentation. You took us right from medical school days to the Clinical Research Institute, where we have got the data about the Olmesartan in so many different areas. And now we really know that when we are managing the blood pressure, it is not just a simple number game. We really look into organ protection, and that is what you have shown, that whether we talk of cardio protection, whether we talk of renal protection, whether we talk of neuro protection, how much this has got an impact. So now we have really got a clarity of picture that how ARBs are becoming the preferred class of drugs, and especially olmesartan, which has got so much benefit, which has, when we talk about not only just organ protection, but additional add-on benefit in terms of anti-inflammatory properties, showing that various markers of inflammation are reduced with these drugs, and there is a hardcore data. And this is what we always look for, because now the science is so much advanced. We always ask from evidence, what is the evidence, and you have given a fantastic evidence-based medicine. What I also would like to focus over here is, whenever we talk about anything, suggestions or recommendations coming over there, so it comes once from the evidence-based medicine. Second is comes from the endorsement base, which has now got the various societies endorsement coming to the ARB class, including olmesartan for it. And third is the experience based. So three E's, what we call is evidence, endorsement, and experience based. And you have combined all three together fantastically. I'm sure there will be a few questions, but before we take up the questions, I would like to have your views and certain discussions on few points which you mentioned. In the initial slides, you mentioned about, when we talk about the statistics about the hypertension and the inertia from the physician and the patient levels. Now, here to some extent, the changing science, which is comes over a period of time, which is also equally responsible, we put it, because there was a time where the medical practitioners used to tell that, okay, if your blood pressure, systolic blood pressure will be, you can keep it high. If you are elderly population, just your upper limit should be 100, or the plus your age. So somebody who is 60, and then if your systolic blood pressure is 160, that is okay. And that was coming through the medical profession. Obviously, over a period of time, we started learning, but then the patient population may not able to still digest it, may not able to accept it. And after the sprint trial, the medical fraternity became so much worried about it, because the sprint has given us the value so down, that
Yeah,
you get worried about that there would be an increased incidence of fall,
yeah.
which could also be there, and which in a senior population. So now in this, what do you feel about the last guidelines? First is target, and second is the for the initiation. So whichever way you think would be justified, and will there be a difference with the age?
Yeah, of course, that in one of my slides that was the thresholds to treat, then I go fast in this because, well, it was not the most relevant for my talk today. But as you say, it is very important. What is recommended is, first of all, we need to take in account in elderly people the level of frailty. In people frailty, we need to be careful. And just if we start antihypertensive treatment, we need to start in levels higher, around when the patient have 160, then start the treatment, and then start step by step. In these patients with more than 80 years old or frail, it is better start with monotherapy than not combination. But the problem of a sprint, you very well know, that is a sprint have one blood pressure measurement unattended. In other words, when the patient is in one room that was not together with the doctor, is not together with the nurses, and in this case, for sure, blood pressure is going down. And to the recommendation of the sprint to reduce blood pressure below 120 of systolic, we in the European Society of Hypertension, we don't accept this. We don't accept this because this is very difficult that the majority of the patients that are seen in primary care that have time for, first of all, that have facilities to have a room aside of the office. This is very difficult. And also, it is very difficult that you have enough time to check the blood pressure carefully. And in this case, well, you can think that we will arrive to close to 120, but in our recommendation, never go below 120. Another thing is 70. Well, in our recommendations, mainly in patients like are the diabetics, if you to reduce systolic blood pressure are giving drugs, and at the same time the diastolic is going a little bit below 70, this can be permitted because the most relevant in terms of risk in this population is more systolic than not diastolic. But then it is the only situation in which 70, below 70 will be allowed and will be safe to maintain. Another issue important in these thresholds of blood pressure is the recommendations of the KDIGO for chronic kidney disease. You know that the recommendation is to bring people to blood pressure below 120/70. This is just only, there are some support in relatively young people, not in more elderly, not today in diabetes. And then this is another of the controversies that we have in our world at the time to select thresholds to treat.
Okay, so that's a very practical point. Now, in continuity to that, in practical scenario, quite often we come across people who are on treatment, especially elderly individual, and on treatment, on follow-up visits, the BP comes to 160/60 millimeters of mercury. Now, the question is, we have a high systolic, we have overcorrected diastolic with a wide pulse pressure, and then how do we go? Should we go for adding or increasing the dose, or we take care of the diastolic?
Yeah, I think that there are clear data in patients with diabetes in which it is you need to reduce systolic. You need to follow treating to reduce systolic. In all the other hypertensives, I think that carefully, if the patients don't have side effects of the drug, you will try to reduce this 160 at least very close to 140, because in this case you are protecting more. That if you live having a little bit scared about what is happening in diastolic. The only situation in which diastolic is not convenient to reduce more is in patients with coronary heart disease. Patients with coronary heart disease, we need to be really careful in the reduction of diastolic, because, well, the possibilities to induce coronary ischemia is higher.
Right. So that's a very good point which you mentioned. Now, every drug has got impact or backup by a clinical trial which changes its future. For example, on target changed the outcome of telmisartan, and afterwards the roadmap trial, which brought two sides of olmesartan, and somehow it was misinterpreted, I would say. People just took it positive side of it, yes, because there was a significant reduction in albuminuria which was there, so there was a good renal protection which was documented. But somehow the cardiovascular events which were misinterpreted, so can you throw some more detailed light on those, because people really took it, and I felt there has to be so much things to be interpreted and read between the lines in the roadmap trial.
Yeah, but this is clear that when there is one big trial, that never will be that replicate,
Yeah.
because it is absolutely very expensive to do that. I was a researcher in on-target trial, that I was there at my institution. We have practically 50 patients randomized in the trial. But I think that one important issue is that the first effect that you need to look in one antihypertensive drug is to reduce blood pressure, and that the blood pressure should be reduced, maintained during the 24 hours, and even more, because there are many patients that there is one don't take the pill the following day, and there are the adherence not it's always perfect. And then I think that this is the first, and in this it's clear that the demonstrations of blood pressure reduction is absolutely mandatory. The other things for sure, and in this case, for example, with the data that you have in reduction of inflammation in the carotid plaques, there are not in other, has not been reproduced in other drugs of the group, because, well, sometimes the studies are planned for analyze specific things. And of course, that in this case, Olmesartan, it's able clearly to reduce inflammation there. That has been demonstrated. This is the last and the more advanced analysis of inflammation in the vessels is the use the PET scan, both. And well, it's information that you have, and you can trust that the effects of Olmesartan in all of this is equal of effective. And also because we are seeing that the reduction in blood pressure is even higher than other ones. I didn't put anything about eprosartan. Eprosartan was not in the eprosartan was there, but Athilsartan was the last one released. And when we analyzed it and compare all the different ARVs, this was not in the market. And then this is why, but I think that is at least as potent as Athilsartan, that many people say that will be the most potent one. But I think that when you use combination, you use with drugs that you can trust with the drugs, because you have a lot of information in the main studies that I showed you yesterday. I think that we are really confident that we are doing a benefit to the patients, and we are able to control blood pressure well, and then that the risk, the cardiovascular risk and the renal risk is becoming less and less and less. according that if we achieve the goals that are recommended in that.
Right. So that was the point which you made it really very clear, and we know that you need to really look at the overall picture rather than just focusing on one aspect of it. Now, talking about combination therapy, now we have more and more recommendations coming from various societies, as you mentioned, to initiate therapy for the combination therapy, because we know monotherapy, we will not be able to achieve the target levels. Now, here my question would be, our audience would definitely would like to know. So, when somebody who's been diagnosed for the very first time at any level, would you recommend to start with combination therapy, or for a small subset of patients where you have a stage 2 hypertension, there only you will require, because it is sometimes it is difficult to pinpoint, okay, no, this patient would go for a monotherapy or this patient should go for a combination therapy.
Yeah, of course. That it's the recommendation of the combination therapy is based in the two main data that I presented before. The first is that you can achieve more rapidly the blood pressure control and also start more rapidly than the protection of that. One of the recommendations that is in our guidelines this year, we emphasize in which when you diagnose a patient with hypertension, in the first 3 months, you should be control this patient, because it is the way to get the greater benefits for the future. And at the same time, you have also that the advantage that the different drugs that you combine can reduce the side effects that the drugs will have. Mainly, if you are giving the patients one thiazide, or you are giving one the hydropyridine, a calcium channel blocker, then the risk to have edema, to have hypokalemia, if the patient is pre-diabetic, or can increase a little bit the glucose. And then if you put together with one blockade of the renin-angiotensin system, automatically the side effects reduce a lot. Sometimes don't disappear totally, but reduce enough for that the patient can be tolerated much better. Because if a patient has side effects, is the best factor that these patients will be not adherent to treatment in the future. This is important. And also, if you have a patient that you start with one drug, well, back in 1 or 2 months, as not controlled, you give another drug, that the patient trusts less with you, that if you give something that this is a pill that control blood pressure faster and without side effects. I think that all these are factors that at the end increases the adherence, and at least, well, together with this, we need for sure that speak with the patient, explain what is the disease, what is the importance. And I know that in primary care, not always you have enough time for that. But well, I think that with the cooperation of nurses and so on, from time to time, we are achieving more control. For example, you can tell you that in Spain, from the last 15 years until now, we have increased approximately 20% the people control. We are achieving 60-65% in primary care.
Oh, great.
That is not the best, but the there is one experiment in some way, because it was not a trial, was in Canada. In Canada, at the first years of this cycle, they start to treat more in combination therapy, and then the rates of control in Canada right now is close to 80% of those hypertensive diagnoses.
Wow.
And was very, very clear relationship in between the percent of people taking combination therapy and the increment in rates of control.
Fantastic.
That is very, very fantastic. Was published for the Canadian Society of Hypertension many, many, many years ago.
Oh, that's good. So now that concept, obviously, which has gone earlier, we were talking about step care approach and starting with monotherapy and increasing the dosage, and gone are the days. And obviously, we have beautifully got the results with your combination therapy at a lower dosage of individual component, which will have the side effect taken care of, and having the different mechanisms of blood pressure which can be tackled at the same time. That's fantastic. So we will take up the questions from the audience.
Oh, yeah.
We have
Okay.
few questions which has come up. And of course, it's really interesting to know we have more than 3,000 delegates who have joined with us today on a Friday evening over here, in spite of it being a working day. And that is what Dr. Professor Joseph Redon, whose name, which when it goes, obviously people would leave their clinical practice and would come to listen to that. So we have a question from Dr. Karmarkar. Of course, he's asking any advantages of Olmesartan over Telmisartan. Of course, you have shown few data, but anything else further which you would like to mention it?
Yeah. Well, what I can say, and that and it is objective, is that the reduction of blood pressure by Olmesartan is better than Telmisartan, and even in the duration of 24 hours, during the 24 hours, as I show in my slides. Never has been done one trial, and never will done comparison head to head. This is not useful. And then you have this data. If you trust with the blood pressure reduction, and you consider that the blood pressure reduction is the most important for your patient, that's I had data, and I tell you one thing. During many years, I was working in research, not only in Olmesartan, also in Telmisartan and other sartans. And then this is what I have objectively, that the trials that I review, doing one not meta-analysis, but a strong and very, very carefully collection of data from, I told you, approximately more than 11,000 patients was in the trials that I show in the studies of 24 hours.
Right. That's
was very large study.
And yes, that is definitely gives us the interesting on the power which is there with the molecule, which you have shown that. That's really good.
And there is another important issue that I think, when you are using combination therapy, it's important to have enough different doses of the combinations, because this allows you, without changing the combination, to move if you need it to increase. This is important. And I was watching what you have there in India, and then you have a very, very wide spectrum of combinations that you can easily combine increasing doses progressively, and also adding in other kind of drugs that today, in the last guidelines, one thing that appears is that one call for don't forget about beta blockers, because beta blockers need to be administered in diseases, and heart diseases mainly, and sometimes you need to combine, and then you have one of the combination with there that is not for the majority of the patients, but will be useful in someone. You will see in the guidelines of the European Society of Hypertension that there is a little bit revival of the beta blocker for specific actions, and if it's a coronary heart disease or heart failure, so on, not more things, because the protection of beta blockers in hypertension is partial. Then this is very well known.
Correct. In fact, you rightly said, and we have seen in a large number of Indian patients, because of the higher sympathetic drive, the beta blockers has got definitely an add-on advantage, and where the combination of a RAS blockade, or especially when we give Olmesartan with beta blocker, will have a wonderful control of blood pressure. That is what we have been choosing. Now here there is a question which comes from Dr. Puri, that which patients will benefit best with ARB plus CCB combination versus ARB plus thiazide diuretic. So any specific...
when you use
Yes.
calcium channel blocker or hydrochlorothiazide, no?
Along with ARB.
Combination. Yeah, for sure. Well, if you are giving with Olmesartan at the same time, there are not too much differences. But if you are giving, I will first to comment giving alone hydrochlorothiazide of amlodipine. When to use one or the other? Well, the first is if you are prone to develop edema, that is women in the 50 and 60 years that have more prone for edema. In this case, move to hydrochlorothiazide. That if no, I prefer always to use calcium channel blocker more than thiazides. If you are combining, well, you need to take in account these two. I say before that if you give at the same time amlodipine and olmesartan, you reduce the frequency of edema, and you reduce the intensity of the edema, but in some patients don't disappear totally. There are patients that are still a little bit, even that improve. In this case, well, I will move to more the hydrochlorothiazide than not in the other one. This is more or less what I do in my practice.
So it is more like a buffet platter which has been kept, and you select which one you want to have for a specific subset of patients, which are useful over there. Okay, there is another question which has come from Dr. Ashish, that if a patient has CKD, is there any way we can diagnose if hypertension is the cause of CKD or CKD is the cause of hypertension?
Well, what is the chicken or the egg of the chicken? Well, that to answer this question, maybe you need to go to the historic of the patient. If the patient is first hypertensive and from time to time glomerular filtration rate or is reducing or is increasing the urinary albumin excretion, you can say that the main is hypertension producing damage to the kidney. But if you suddenly you have a patient that appears with a reduction in glomerular filtration rate of his proteinuria of albuminuria, and start and you detect blood pressure, high blood pressure, well, the first you need to check for what are the potential causes of this chronic kidney disease. You need to do a checkup in order to check if there are proteinuria. Then you need to be more careful, because it's not frequent that one patient with hypertension and chronic kidney disease develop proteinuria rapidly. And if it's a proteinuria with nephrotic level, for sure than not. Then I think that in this case, you need to see what happened in the patients in the years before. It's much more frequent that the chronic kidney disease will be produced by hypertension and diabetes than not for one primary renal disease. This is much more frequent. Whatever the case, at the end, in terms of control blood pressure, I am just right now writing a chapter for a book about the treatment of hypertension in chronic kidney disease.
Okay.
Then, at this point, you need to consider more or less the recommendations that we have previously. But here, if there are albuminuria, you have a new drug that you can introduce together with the antihypertensive drugs that are the inhibitors of SGLT2 inhibitors. And then that this is recommended today because they also reduce a little bit blood pressure more. But then, and if we are speaking about chronic kidney disease and the physician need to give drugs to the patient, it is expected that with using ARBs or ACE inhibitors, it is expected that in the first month or 2 months, there is a decrease of the glomerular filtration rate. If this decrement is less than 20%, doesn't matter. This protect in the future. This protect for the future. If it's in between 20 and 30%, well, be careful, reduce doses. And if it's 30% or more, you need to take out the possibility that renal artery stenosis, or you need to take out this medication that you are giving to the patient. This is a very important one. And if you are giving and you start treatment with ARBs or ACE inhibitors and SGLT2, the probability that decrease a little bit the glomerular filtration rate in the first month is even higher. But well, it is also protective. Then we need to be careful, follow that this is okay, not hyperkalemia, and then maintain the treatment for the reduction of risk of progression in the future.
Right. So it is really sometimes becomes a double-edged weapon when we start using in CKD patients. And quite often we come across such situation whenever there is on-board ARBs like Olmesartan in a CKD patients, and the patient goes to nephrologist. So what they do is, that is commonly, if the patient is having ARB on board, they knock it off. And if they are not on board with ARB, they will add ARB. So it is always the opposite which they would do. So here my question would be, is there any particular level of serum creatinine or serum potassium level?
Well, it's
you would be skeptical about going further with that.
Well, when they are arriving to 30 of filtration, they start to be a little bit cautious, and then below 15, sometimes they prefer to take it out. Even that, the protection of for events in the future, not for the renal function, but the events of the future. If it is possible to maintain and the patient is tolerant, is much better to maintain a blockade of renin-angiotensin system for all the other actions that they have.
Okay. So that is one thing which obviously needs to be taken care of. So here, after starting Olmesartan or other ARBs, how frequently would you recommend for doing the creatinine and potassium level?
Well, if it's one patient that is have a previously normal renal function, then in 3 months I repeat analytics in there. But if you are in one patient with chronic kidney disease, then what is it's really useful, and we need to do one control about creatinine and potassium. That this is the other one. You need to be careful in the first month of treatment.
Right.
Because mainly if this patient has not been treated previously. If has not been treated previously, you don't know what will be the response of them to the drugs. But both together, creatinine and potassium levels.
Right. And secondly, what has been observed also that those who are bit over diuretized or using, getting into hypovolemic state, and because of now fluid has already been taken care of, and if still they are on diuretic and if they are taking ARBs, then probably reduction in EGFR and the rise in potassium is much more marked in such patients. So probably diuretic dosage needs to be optimized when treating with ARBs.
Sure. Then the question sometimes is starting with thiazide or thiazide-like diuretic or with loop diuretics, Henle loop diuretics. Well, both are effective, but the nephrologists, when the filtration is below 30, they prefer the use the loop diuretics. But sometimes if mainly if there are other factors that increase the enlargement of volume, such as the heart failure at the same time, in this case, even can be combined loop diuretics and clortalidone.
Oh,
This is just if there are the patients needed, I told you, below 30 milliliters, and also edema, and then patients with one important over side volume. Even combination, but it can be useful.
so probably over a period of time, if we start getting those fixed dose combinations, it won't be surprising. We would get it since we have got the varieties of, as you said, fixed dose combinations.
We need to consider that in patients with chronic kidney disease, the percent of resistant hypertension is high.
Yes.
And the percentage increases at the same time the glomerular filtration rate decreases.
Right.
And then when you are around the 30, in between 15 and 30, practically 60% of these patients are resistant to hypertension, to treatment. Right. Then it's, and in those with stage 3A, it is more or less 22% resistant hypertension. And this is increasing according the glomerular filtration rate goes down.
Yes.
And then you need to use combination therapies. The question is, when you arrive to 3 drugs, what is the 4? The 4th drug.
Yes.
Then mainly in these patients with very low are not recommended to go to spironolactone because the risk for hyperkalemia is really high. And then you need to manage others and other drugs that are coming that are close to the market.
Right.
I suppose that in the last 2 years, will arrive to the market at least a couple of drugs that can be used in these conditions.
Right. Practical difficulty. Right. Now, we have seen from the data, of course, we know that Olmesartan, which is truly once a day therapy. So, practical questions would be, which will be your choice, to give it in the morning or to give it in the
Well,
evening?
then this is one question that always appears. Well,
I know.
do you know that there are some studies published in good journals that say that if you give the drugs at night, you save 30% more the risk of cardiovascular disease? Well, this fortunately, 1.5 years ago, one big study with more than 20,000 patients demonstrated that there are no differences given in the morning or in the evening. My recommendation is in the morning. In the morning, mainly and only, you need to consider use drugs that was clearly demonstrated that have 24 hours action. And then it's forget about the administration of the pills at night. Well, you can administrate one pill at night if you want, if you are giving 4 to the patients, or one pill triple that, but no more. Well, for men, you will give one that drug for prostatics subjects at night that also
Right.
reduce a little bit blood pressure. But well,
Alpha blockers, yeah.
no, that's a sign.
Right.
Well, but this is a night for sure.
Okay. So I would put it here. I also fully agree with that. And I tell that suppose if you are forgetting in the morning, you may remember it
Yeah,
after 2, 3 hours, 4 hours, still you have a time to, take it. Whereas if you are missing
yeah,
at night, you will directly get up in the morning and you have
yeah.
lost almost 12 hours at the time. So
No,
that's the
no, no.
point also. So I think we have covered most of the points. There was a one good comment, I would say rather, it is a comment which has come from Dr. Preeti saying that Olmesartan can be considered a 360-degree ARB with the evidence of LVH regression, reduction in microvascular complications, inflammation, proteinuria reduction, improvement of vascular compliance, and reduction in atherosclerotic burden. So, can Olmesartan be a preferred ARB amongst all ARBs, which we know, which has been already presented, and
Yeah,
probably after listening to all this, I think we feel like the title has to be changed. No, it should not be just from pressure to protection. I would say from pressure to power packed protection, so that it is
okay, yes.
multiple P's which are there with this molecule, where we can achieve and offer a significant advantage to our patients of hypertension. And here, before we end, I would say it reminds me a beautiful quote from Sir Alvin Toffler, who states that illiterate of the 21st century are not those who cannot read or write, but those who cannot learn, unlearn, and relearn. And we are here with Professor Joseph to learn so many new things which we realized also. So I'm really thankful to Professor Joseph, who had really thrown a wonderful light on the molecule olmesartan with the real evidence which was there. And I'm sure all our delegates who have participated has gained a lot out of it. So thank you so much, sir. And with these words, I would hand over back to Dr. Parthasarthi. Thank you so much, sir.
Thank you. Has been a pleasure to share with all of you these minutes about discussing about hypertension. That's
Thank
was a
you.
real pleasure. Thank you very much.
Thank you so much, Professor Radon. Thank you so much, Dr. Mehta. We have literally received, we've had a very engaging audience, a 3,000 plus audience, probably a few stray comments asking for a version 2.0. So That's the impact of the session. And we are thankful to Professor Redon and to Professor Mehta for so wonderfully bringing out practice perspectives that can be implemented actually in the clinical scenarios. It was not just a rote discussion on trials, but also a translation of clinical trials to clinical practice, more a bench to bedside approach, if I might say.
Yeah.
So we take. It's been an honest pleasure to hear Professor Redon, and a huge thanks to Professor Mehta for that wonderful moderation. We thank you too, dear audience, for taking your time, as Professor Mehta just said, on a weekday for logging in and showing such interest in numbers. Last but not the least, we also thank our uh, scientific and technology partners, Medways Healthcare, for aiding us with this webinar. Thank you, one and all. Have a great day.
Oh, thank you.
Bye-bye.
Bye. Bye-bye.
Thank you, sir. Thank you, Professor.
Bye.
Bye-bye.